great pleasure for all of us to welcome tonight from Miami, Florida, the Director of Sales for Europe from New World Medical, Mr. Mauricio Fraginals, and Dr. Mohamed Sayed, that he came from Florida to explain and to make a presentation about the Clear Path, which is very important, most all of us.
Okay, well, thank you, Nicholas, and first of all, thank all of you for coming out tonight. I think as a global community, we've been through a very rough 20 months, and it's nice that we all are starting to travel again and meet in person, and not just meet through a computer screen and through ESCRS or ASCRS online. It's good to see people again and interact, and thank you all for coming out tonight. Again, I want to thank Nicholas and Optical Solutions and Dr. Sayed for coming out tonight. This is very important for us to launch the Clearpath here in Greece. It's been a long time. We wanted to do this before, but because of COVID, we didn't want to launch Clearpath or any products without properly training the physicians and coming out and visiting with you and speaking about it and having you guys answer any questions that you may have. So we've been wanting to do this for at least a year and a half now, but we've been putting it off to make sure that we do it right. And thank you again to Nicholas and to his whole team. I think this is the perfect opportunity to launch, and hopefully you guys get a lot out of this meeting, and we'll be here to answer any questions that you may have. Thank you.
Thank you, Mauricio. Mauricio is very helpful to our company. And you know that New World Medical is one of the biggest companies in the world, from Los Angeles, from the United States, and they are doing a great work. So the microphone now goes to our doctor, Dr. Mohamed Sayed.
Good evening, everyone. Thank you so much for coming tonight. And it's an honor to be here in Greece, amongst my friends and my colleagues. And I really, Greece has always been on my to-do list. And I'm originally from Egypt, and we have this sentimental feeling towards Greece. We love Greece so much, and we love Greek food, and we do have some very similar items in our cuisine menus. But so I've always wanted to come to Greece, and my wife is very jealous right now. She's in Florida, and she's texting me every minute, and it's like, can you take pictures, show me what you're doing? So thank you so much. I'm really happy to be here. I'm actually a glaucoma specialist. I work in Vero Beach, Florida, but next week I'm actually moving to Dubai. And I'll be a consultant glaucoma and cataract surgeon in Moorfields Eye Hospital in Dubai. I still hold a faculty appointment at Florida State University College of Medicine. And I'm dual trained in glaucoma and pediatric ophthalmology at Bascom Palmer Eye Institute at the University of Miami. So I would like to thank New World Medical. We have done some great work together. I was just telling Mauricio that not only do they have great products, but the social responsibility and what they do in terms of charity and reach out activities is unbelievable. Every time I had a patient who needs a tube free of charge, they don't have insurance or anything like this, I had it before I even finished the sentence. So thank you so much, Mauricio. I also would like to thank New Optical Solutions for the hospitality and for the arrangement of this really nice meeting. And hopefully you guys will all find our presentation today useful. Now, very, very special thanks to my very good friend, Dr. Vasilios Diakonis, who's a cornea specialist, and he trained with me in Bascom Palmer. I was a glaucoma fellow, he was a cornea fellow, and it was a great reunion together with another good friend of mine and a Bascom Palmer alumnus, Dr. Demetria Portalio, who's actually in, she's a consultant in the UK, so she had to travel today to London, but I was lucky enough to meet them both last night, and they took me around, and it was a great night, so thank you, Vasilios, thank you so much. So, the outline for our talk today. We're going to go, I know a lot of you are very accomplished glaucoma surgeons. I already spoke with some of you, so some of what we're going to go over tonight is actually basic, but I think for surgeons who have not done enough, like glaucoma drainage implants, they might find some of the basic stuff a good refresher. And so we're gonna do a short overview of glaucoma drainage implants. We're gonna talk about the new Ahmed Clear Path design, and I'm gonna share my technique of choice, which is the small incision taco technique, Clearpath 250. Now, Clearpath has been around for like a little more than 2 years, correct, Mauricio? Or about 2 years. I have seen techniques evolve like crazy. Every day I find a video online of a modification of the technique. So this is not the only technique, but this is how I do it, and it works very well for me. And we're also going to go over the basic technique of the Clearpath 350, which for people who are familiar with the barbell 350 is not very different, but there are some nuances and key differences between the barbell 350 and the Clearpath 350, which we're going to go over. And we're going to go over some surgical scenarios and special situations. And then some pearls of wisdom for post-operative care, what I do post-operatively, how I manage my patients. And then we'll give you a chance to kind of ask questions. So if we look at this graph, it's a bit old. It's like a decade-old graph, but I found that it's very useful. From the mid-1990s to about 2010, we see that there had been a consistent and continued decline in the number of trabeculectomies that are being done in the United States. So, the trabeculectomy arm in yellow, is going down as you see. And this isn't, can be attributed in part due to the advances in medical therapy. So around the mid-1990s, we had the introduction of the prostaglandin analogs, and some of these very potent medications actually made surgery a little bit less needed early on in the course of the disease compared to what was happening before the introduction of beta blockers and prostaglandin analogs. But we also find at the same time that the number of glaucoma drainage implants that are performed in the United States has been steadily going up in the same time period. However, trabeculectomy continues to be the most commonly performed surgical operation for glaucoma. I don't think that this, the cropping of the picture was a little bit more than I wanted. So the arms are different. The trabeculectomy arm on the left is in tens of thousands, while the glaucoma drainage implants is in thousands, not tens of thousands. So trabeculectomies are still being the most commonly performed surgical operations, but certainly not as much as they were a couple decades ago. So a historical perspective of glaucoma drainage implant. So it dates back to the early 20th century, and they had a horse hair that they cannot place across the AC and allowed controlled leakage. Don't know what they did about infection at the time, but like, you know, apparently it did do the job at the time. A little bit later, they placed a rod, a hollow rod, and the procedure was called acuplasty. And but it wasn't until 1968 until like modern glaucoma drainage devices had been introduced, namely the Multino implant. So the idea behind the glaucoma drainage implants is very simple. You have a tube that goes in the anterior chamber, can also go in the posterior chamber or in the vitreous cavity through the pars plana, but mainly, like the vast majority of tubes go through the anterior chamber, and it maintains the patency of the sclerostomy. Like, you know, the sclerostomy simply doesn't close because the tube is in there. So it maintains the patency of the fistula, and then that tube is associated to an end plate that is placed equatorially, you know, on top of the sclera, and it forms a fibrous tissue capsule around it that actually kind of like becomes the reservoir of all the fluid that exits the eye through the tube. So that capsule that forms around the end plate of the glaucoma drainage device really offers resistance to flow. So if you have a really big capsule, you will have lower pressures because more fluid is going to exit the eye and the resistance is going to be low. If you have a thick, fibrous, tight capsule, or what we call a ring of steel, you know, then like the resistance to the outflow of aqueous through the tube is going to be very high, and the pressure lowering of the tube is not going to be great. So at the end, like the two factors that really determine the final intraocular pressure is how thick the capsule is. That's number one. Number two, what is the surface area of that capsule, which is also related to the surface area of the end plate of the glaucoma drainage implant. But this raises the question of, is bigger always better? Up to a certain point, that's true. So if we look at the Ahmed glaucoma valve, which I believe many, if not all of you have been using, the Ahmed glaucoma valve has a plate surface area of about 184 square millimeters. And it does lower the pressure to a degree, but like if you look at the ABC study and the AVB study, it may not lower the pressure as much as a 350, because the Barber 350 has a, like, you know, larger surface area. So one of the reasons. So the final pressure is determined in part by the surface area of, like, you know, the end plate of the tube. However, after you reach a certain threshold, and some may argue that this can be at 250 millimeters of mercury, any addition to the surface area of the plate may not necessarily translate into lower intraocular pressures. I was having a discussion today with the doctor. I always said this, like, you know, there is no, not a single study that actually shows a difference between a 250 sized plate and a 350 sized plate. The doctor has said that he probably had seen one, and he was going to send me evidence of that. But you know, the significance of such difference in after you hit the 250 threshold is probably arguable. I still put in 350s in some situations, which we're going to talk about. But I have, like, you know, been putting in 250s with great results, and we're also going to talk about, like, you know, why a 250 might actually be the better choice in my opinion. It's worth mentioning that at some point we had a Barlow 500. So it was a very, very big barbell, but they found no significant difference really in pressure lowering between a 350 and a 500, and they actually stopped doing the 500. So traditionally, glaucoma drainage devices have been done later in the course of the disease compared to other, surgeries like trabeculectomy, for example. So traditionally, glaucoma drainage devices were done only after a failed trabeculectomy, or when there was a conjunctival scarring that would limit the feasibility of doing a successful trabeculectomy, like after, for example, a conjunctival surgery, like for strabismus or for vitreoretinal surgery. Neovascular glaucoma was another condition in which trabeculectomy didn't really do very well, and tubes, primary tubes were indicated traditionally. Uveitic glaucoma is another one. Epithelial and fibrous downgrowth, and childhood glaucoma that is refractory to goniotomy and or trabeculotomy or trabeculectomy, and an aphakic glaucoma. So these are an aphakic glaucoma simply because if you have a bleb, you're not going to be able to fit a contact lens to correct the aphakia. So these have been the traditional indications of a glaucoma drainage device. However, the indications have actually expanded over the last few years. To the extent that some programs in the United States, I'm not saying that this is correct or this is right, but some programs in the United States stopped teaching trabeculectomy. Now, this is in part thanks to the results of the TBT study, the trabeculectomy versus tube study, which was, I come from Bascom Palmer, which is the birthplace of the TBT study. And the TBT study, in short, compared Barlow 350 to a trabeculectomy in eyes that had undergone an ocular surgery. Most of the eyes had prior cataract surgery. And it did find that, the Barlow 250, the Barlow 350 group was safer with at least equivalent pressure lowering initially, and it didn't fail as quickly at 5 years of follow-up. Now, after the TBT came the PTVT, the primary TBT, but a lot of surgeons had already switched completely from trabeculectomy to tubes after the results of the TBT study. During that time, the few years that are between the TBT and the PTBT, a lot of programs have already switched 100% to 100% tubes and stopped teaching trabeculectomy. So there is a certain generation in American glaucoma specialists who don't do trabeculectomy. And the PTBT actually, it kind of reversed that to a degree. So if in patients who didn't have a prior ocular surgery, namely cataract surgery, they didn't have any cataract surgery or glaucoma surgery in the past, particularly those with baseline pressures that are less than 25 millimeters of mercury, they found that trabeculectomy may offer better efficacy with similar safety compared with the Barlow 350 implants. So there has been some resurgence in the adoption of trabeculectomy after the results of the PTBT, the 3-year results have been out. If we look at the overview of the implant design, the implants differ in size. We have the 184, the Ahmed valve. We have the 250 barbelled and Clearpath, and we have the 350 barbelled and Clearpath. The shape, they look different, and we're going to go over the shape. and the material they are made of, and whether they are valved or non-valved, and this is a very important difference. So the valved implants really have a valve mechanism, and the valve mechanism prevents the pressure from going too low. So you put in the tube in the eye, which is attached to the plate, and it has a valve. And the valve is designed, at least theoretically, so that the pressure, it's open and it's allowing, the fluid to exit in one direction from the eye to the outside of the eye, as long as the pressure is above 8 to 10 millimeters of mercury. When the pressure drops to that level, the valve closes and it guards against hypotony. So that's the main advantage. It does give you immediate pressure lowering, and it has a safeguard against the pressure going too low. And this is where the beauty of the Ahmed FP7 still lies. It's the only tube that's currently available that actually brings the pressure down immediately. You have immediate pressure lowering, and you have a safeguard against hypotony. Not to say that hypotony doesn't happen. It does. Some valve failure, we see valve failure from time to time. But if you have a patient with neovascular glaucoma, a monocular patient with very high pressure, you can't wait, you need immediate pressure lowering, or you have a eugenic glaucoma, or a patient who had vitrectomy before and a high myopia, very susceptible to the complications, the bad complications of hypotony, you may want to put in an Ahmed FP7 because it safeguards against hypotony. And this is the valved implants. Now the non-valved implants, they don't have a valve mechanism. So if you put in a tube in the eye, and the eye is simply going to shrink like a raisin. All the fluid inside the eye is just going to exit. So there has to be another mechanism by which we restrict flow that is not built in the device itself. Among those is the Barvel tube 250 and 350, and now what we're talking about today is the Ahmed Clear Path 250 and 350. So again, which way to go? The Ahmed glaucoma valve or the non-valve tubes? The ABC study and the AVB study have shown that the non-valve tubes do have better pressure lowering capability. So the efficacy is in the side of non-valve tubes. The safety, the safeguard, the guarding against hypotony is actually in favor of the Ahmed glaucoma valve. So there is no right or wrong answer. You want to see, if you have an older patient in their 90s, life expectancy of another couple of years, you just don't want to, have them lose their vision before they, pass. And, they have uncontrolled pressure, and they had a history of uveitis and a history of vitrectomy, and a patient who's, and they are monocular. Now, I'm not going to go in and put in a non-valve tube. I'm going to go and put in an Ahmed glaucoma valve because I want to, have a safeguard against hypotony as much as possible. Now, it's not going to lower the pressure probably as much as a Clearpath 250 or 350 would, but at least I'll sleep better at night knowing that in the first few weeks after the surgery, they are not going to develop kissing choroidals or suprachoroidal hemorrhage. So this is one hypothetical scenario in which I would use the Ahmed valve. Another situation is neovascular glaucoma. A lot of these neovascular glaucomas are actually monocular patients, and they come with very, very high pressures, 40s and 50s, on maximum medical therapy, including oral citazolamide or carbonic anhydrase inhibitors. And you need to bring the pressure down. As we will see, all the non-valved implants, they don't work for the first few weeks. If you have a monocular patient with a 0.95 cup, tubular field, and like, really high pressure, you don't want to wait. Like, you put in an Ahmed, and if it doesn't, it will give you immediate, the FP7, if it doesn't give you like, long-term pressure lowering, you can do something about it at the time. Many patients don't need anything else, but like, it will give you immediate pressure lowering and will allow you to save that eye. So these uveitis is another thing. Like uveitic patients are very susceptible to hypotony and to developing complications of hypotony. Hypotony itself is not an issue. The problem with hypotony is how persistent it can become. Uveitis helps keep the pressure low. It makes the the hypotony persistent. And this is the problem with uveitis, and therefore, like, the FP7 AGV might actually be safer in these eyes. So now we move to the design of the Ahmed Clear Path. We have two models, the 250 and the 350. The 350 is a winged end plate. So it has two wings that go under the rectus muscles. If you put the tube superior temporally, which is the most commonly used quadrant or the most preferred quadrant, then one wing is going to go under the lateral rectus and one wing is going to go under the superior rectus. Now, if you go intranasally, it's going to be the medial rectus and the inferior rectus. If you use the Clearpath 250, it's a single quadrant implant. So it fits between the two recti. You don't need to hook the muscles, you don't need to even expose the muscles. And it just fits beautifully in between in the quadrant. This is the difference in shape between the Clearpath and the barbell. So if we look at the 350, you will see that the Clearpath has a bigger anteroposterior diameter. We will also see that the eyelets of the device are more anteriorly positioned. And this is very important because, why is it important? Because it makes the insertion so much easier and the access so much easier. So instead of you trying and kind of fighting to reach really back and get the barbell, the sutures and the eyelets of the barbell, the Clearpath is there for you. It's all anteriorly positioned, and this is true for both the 350 and the 250. And there is a difference in the 350 in the wing design, which we're going to see in a second. And for the 250 is just a completely different design. So the 250 barbell is actually still a winged design that still needs to go under the rectus muscle. You still need to dissect the recti and isolate them, and still has eyelids that are posteriorly positioned. Now, like the Clearpath 250 is everything that the barbell does not. Moreover, the Clearpath is actually more contoured. Both of them, they are more contoured compared to the barbell, which are flatter. And number three, the material that they are made of is very malleable. So you can actually fold the Clearpath in your hands or in between, the arms of a forceps, a pair of forceps, while you can never do that really with the barbell, which is very rigid. So if we look at the 350 barbell versus the 350 Clearpath, look at the wings of the Clearpath. The wings of the Clearpath, they have that notch here. They have this notch, and this notch here doesn't rest or doesn't let the wings rest against the insertion of the extraocular muscles. While with the 350 Barvo, see how much, like, you know, it's really encroaching upon the extraocular muscles. And some doctors do place it a little bit more posteriorly, which like does create an access issue. Because, like, you know, this will just like bring back the eyelids even more backward, and it just becomes a more difficult situation. And if you leave it, like, you know, kind of like, you know, encroaching upon the insertion of the extraocular muscles, you know, you are more likely than not going to have a patient who's coming to you very upset that they have double vision. Now, this is not the same really in my experience with the Clearpath 350, although I am not doing as many 350s as I used to right now, because I get great results with the 250. So again, the wings are away from the muscle attachment points with the Clearpath 350. So if you place a barbell over a Clearpath, this is what it's like. Okay, so the barbell is on top and the Clearpath is at the bottom. So in both the 250 and the 350, the anterior posterior diameter of the plate is actually bigger for the Clearpath, and the horizontal diameter is actually smaller for the Clearpath. So for the 350, it gives you, like, you know, theoretically easier insertion of, like, you know, under the muscle. And for the 250, you completely avoid muscle insertions, 100%, because it's a single quadrant placement. Now, how do we control the flow? Like, we know that, like, the Clearpath and the barbell are non-valve implants. So there are several techniques. And I'm going to tell you what I do. What I do is I use a ripcord, which is a nylon suture, or a suture of another material that goes into the lumen. It's an intraluminal stent, and that partially occludes the lumen of the tube. And then I tie a vicryl ligature around the tube, and I want to achieve complete water tightness. Now, the material of the tube itself, of the Clearpath, is the same exact material as the barbell tube. Having said that, almost all surgeons that I've spoken with report, like, you know, some challenge, like, you know, kind of achieving water tightness of the Clearpath tube compared with the barbell. It's not as straightforward. Last week, actually, I had a call from a colleague in Puerto Rico, and he said, like, you know, I'm going to return these. I can not, like, get them to actually occlude and become watertight. And I showed him this technique, and he tried it, and it did work for him. So this is not my technique. This is actually a technique that I learned from another colleague. His name is Dr. Mohamed who works in Ocala, Florida. He's a glaucoma specialist. And so I call this El Mala loop. So typically for people who are used to doing the barbells, what you do is that you do a three throws followed by one throw followed by one throw, and call it a day. What Mohamed Mala does differently is that he loops the vicryl around the plate before doing the 3-1-1 throws. And I'm going to show you this in a video. So this is me. This is how I go about it before I actually start the surgery. So I put the tube on the patient's forehead, or, like, you know, the patient's still not ready, I actually, like, do it on the main stand. I stabilize it with, like, steri strips so that it's stable on tying the tube. The ripcord, it comes pre-placed with a ripcord suture, a 4-0 Crowley. Now we get a segment of Vicryl, 7-0 Vicryl, and this is what I use. I have a straight tire in my non-dominant hand and an angled tire in my dominant hand. So it goes underneath the tube, and then I loop it. So now I have a loop. I don't start tying without looping it first. That's key to achieving water tightness in my experience. Then you throw in the 3-1-1. Actually, D3-1-1-1-1 because I'm OCD, but 3-1-1 are certainly enough. And you try to lay it flat. If it's not flat, just raise it up until it becomes flat, and bring the two loops in line to each other. And then when you start tightening it, tighten it between the fingers, not with the instrument. This is another key. So if you're going to actually take two key points from me today, they are both in the tube tying technique, and it's loop first and tighten with the fingers. This is key. Since I started doing this, I rarely, when I test tube water tightness, I rarely find any leakage, like almost zero. So I tighten it in the fingers. Don't pull too hard because you can actually bisect the tube. It does happen in the hands of fellows, and the professors are pretty upset. Typically, obviously it happens. So that's enough. I put in two more. That's just me. Now you test the tube. You create a column of air, and then you bring a 27 gauge needle, and you go into the lumen of the tube, and you inject BSS, and you can see how the BSS is actually, like the bubble, the air bubble is moving up and down the tube without any leakage in this end. So that's it. That's a tube that's not gonna leak. That's a tube that you're never gonna have early postoperative hypotony with. So I'm gonna actually go over my technique of 250 Clearpath, which is the taco technique, or small incision technique, which takes anywhere from 15 to 20 minutes. This is the entire time that the surgery takes, as opposed to 45 minutes to an hour for 350. And we're gonna discuss why this is important. But I'm gonna play an unedited video that's gonna take 16 minutes, in which I place the tube in the eye of a 93-year-old, and it takes only 16 minutes. And I'm gonna talk as we're doing the thing. So I start by placing a traction suture. This is a double-armed Vicryl suture. So it's double-armed, and it doesn't necessarily have to be. I use the double-arm, or the two arms when I really do the fornix-based incision, and this is a limbus-based incision. So doesn't make that big of a difference, but if you have it, you can use it in case you switch to fornix-based. And then I put it on a pair of locking needle holder. And I give it to my assistant. And my assistant moves the eye wherever I tell them to move it. Then I get calipers and I mark them and open them at 4 millimeters. And I go 4 millimeters wide and 4 millimeters behind the limbus and make this mark. Then I use a non-toothed forceps, a conjunctival forceps, and a blunt Westcox scissors, and I make a 4 millimeter incision in the conjunctiva and in the underlying tenon. Make sure you open the tenon well. And then you dissect in all directions, making sure you dissect well temporally where the tube is actually, the ripcord suture is going to go.
Yeah, keeps getting shorter or longer or longer.
Okay, so I don't typically cauterize unless you absolutely have to. If there is some profuse bleeding, but otherwise I don't necessarily use cautery at all. So posterior dissection, and here I only use the Westcott scissors. I don't use a tenotomy scissor for this technique, for the 250. And then all of this was under topical. Now I get a 19 gauge cannula and I inject some block in a subtenon or slash peribulbar fashion. And that really keeps all my patients very comfortable. I don't block them before the surgery. And then I dry. There is no significant bleeding. I determined that it's not necessary to cauterize at this point. Now, okay, we're gonna wait here. I'm gonna pause. So, what I did is that in one hand, my dominant hand, I had a .12 forceps, and I wrapped the Barville the Clearpath 250 in the fingers in a taco fashion. Actually, this is more of a burrito fashion. It's more wrapped. So I did that, and then I held it with the .12 forceps, and then the other hand, I have a conjunctiva non-toothed forceps that I open that pocket with, while my assistant is giving me exposure and traction, pulling the eye down and in. Infranasal. And I insert the Clearpath, the tacoed Clearpath, through that really small incision. See how malleable it is. This is unseen in any other plate material, in any known glaucoma drainage implant. You can do nothing like this with the Barville. It's very rigid. And this is the ripcord, which I'm gonna shorten a little bit and then tuck it under the conjunctiva, under tenon actually. And then, this is like, here it is. I go back about like 8 to 9 millimeters for the eyelets, and I no longer measure that. It's really by feel after I've done so many. But this gives you an extra 2 millimeters. So if you actually put it 8 millimeters back, the plate itself, the eyelets are anteriorly positioned. So the plate itself starts 2 millimeters behind that. So if you put it at 8, the eyelets at 8, the plate is at 10 millimeters. And then I use an 8-0 nylon to fix these eyelets. I'm asking my assistant to dry. Taking her a little bit of time. And just a simple 8-0 nylon 311. Clear the needle of the tissues. Obviously, there are so many different ways of actually suturing the plate to the sclera. Of course, this is a nylon suture, so it will have, like, you know, pointy tips. So after you trim the suture, we make sure to rotate the knot into the eyelet. So this is the first eyelet. This is the second eyelet. It will do, you know, the same thing. I'm going to fast forward that. And all this, like, you know, only 10 minutes and a half had passed from the surgery, and the plate is already in. Now, I trim the tube. Everybody has their own preference. I like to have like 2 to 3 millimeters of tube inside the eye. So I trim it. Yeah, about perfect for me. And this is actually what I do. So the 23 gauge needle that comes with it will give you a very snug fit. So like, you know, the tube, if you have a long track, you know, the tube will fit perfectly into that track. You can go, there are so many ways of creating that, like, you know, tunnel. What I do is that I go about 2 millimeters or 3 millimeters behind the limbus and go in like within the sclera and then change the direction of the needle to go in parallel to the iris. And you know, that way, like, you know, I don't end up, like, you know, very close to the cornea, and I don't end up, like, you know, too deep, like, you know, or like, you know, risking the tube to be blocked by the iris tissue. And always, of course, making sure to have the bevel away from the iris. So if you're putting it in the AC, it will be beveled up. If you're putting it in the sulcus, it will be beveled down. And this way, you make sure that the tube remains patent. Then I grab a pair of needle holders, and I actually tie, like, you know, bend the needle to an obtuse angle. This is key if you want to do this tunneling technique, or, like, you know, intermediate length tunnel. So if you see, this is the length of the needle itself, the needle tip itself. I go back to, like, you know, double that distance. So another distance like it, about here, and then I put it here, like, you know, in the hub of the needle holder, and I bend it to an obtuse angle. and I mark it so that I know exactly where I'm going to go. Again, these are little nuances, but like everybody has their own routine. I'm telling you what works for me. See, this is about 3 to 4 millimeters behind, and I go in the sclera until I reach the limbus, and then I change direction and I go in. When you're coming out, it's very important that you don't depress, that you go up. Otherwise, you're going to actually create a false passage, and the tube will end very close to the cornea. So these are very little nuances, but they are important if you want to have perfect results. So this is a longer than usual tunnel, but this is how I like to do it. And then it's a very snug fit. It goes in. By the way, this eye is not opened. I haven't opened the eye at all, except with that, one thing, the needle track. It goes in, I'm very happy with it. Then I get a patch graft, a sclera patch graft, and I put it on top. Do you need to suture it? Well, if actually you do, if you have a fornix-based incision, you do need to suture it because it can be displaced. But with this limbus based flap, you don't really need to suture the patch graft. It's not going to go anywhere. There is no space for it to go anywhere. So I just put it in. I don't glue it and I don't suture it. It's just goes in, stays there, never really moves. And then you have this really little peritomy that you made initially, which you can now suture with 2 or 3 interrupted sutures, and 2 are enough here. I take big bites and I incorporate tenons so that you don't have any exposure to the patch graft. That's it. I cut these, and we are 16 minutes, 28 seconds, and call it a day. This is my routine Clearpath 250, maximum of 20 minutes. Now, it hasn't been a while since I have done a 350, simply because I'm very happy with this single quadrant small incision taco technique 250. So I don't have a video of my 350, so I asked one of my mentors in Bascom Palmer, his name is Luis Vasquez, and Luis yesterday kindly sent me his video of a 350, which was a 55-minute, it's several videos, but collectively 55-minute video. And Luis is a very experienced surgeon. I mean, he's a perfectionist, but just to show you the contrast between a 250 and a 350. Now, is there a difference in pressure lowering? Maybe. I'm not sure. Until we have a head-to-head study, I'm not sure. But in my opinion, I think that the less tissue trauma that you do to the eye with the 250 small incision technique, and the efficiency and how streamlined you can get it, I think it's not worth it for me, except in certain situations, to go for the 350. But I'm gonna show you how Luis actually does his put the plate under the muscle. That's the part that I'm gonna show you from his surgery. So what he does, of course, you need to actually have extremely good dissection. You need to isolate the muscles, and you need to make sure that underneath the muscles, all the intermuscular septum is totally severed. Why? Because with a barbell, the barbell is actually rigid. So if there are, like, you know, some remaining fibers of the intermuscular septum, like, you know, the barbell is going to cut them on its way in. But with this malleable material, it's not. And you can have a really difficult time kind of trying to get the tube in if it's not extremely clean underneath the muscle. So you need to kind of take your time and really do a great dissection and cut all the intermuscular septum really well. So, you know, you go in with a couple of muscle hooks, and with one muscle hooks you depress, and with one muscle hook you push up. And then your assistant, or like if that might be your assistant, you know, and you would go in with the first wing. See how big of the peritomy is? It's just very different. It's a very different surgery. Now, like, see how he's folding the plate, and the wing is actually going underneath the body of the plate here so that it can fit in easily. Making sure that he's going absolutely under the muscle. Not that, like, you know, a big problem is going to happen if you put the wings above the muscle, but some surgeons prefer explicit under the muscle placement. So here, the first wing is in. Now, like, you know, hooking the second muscle. The assistant's still holding that. And you're trying now, they're trying to kind of unfold. Yeah, it's a long video and it's like on several. They're now are going to unfold the second wing in order for them to actually put it under the muscle. A fellow is assisting Luis, so that's also one reason it might be taking longer. Still. See how clean and beautiful the dissection is. Like, you know, it needs to be absolutely clean. And then, yes, the second wing goes under the superior rectus. And, you know, they tie the nylon similarly to what I did, and the rest of the surgery is similar to, like, you know, any tube. Okay, so what if you don't have a patch graft? That's not only for the Clearpath. What if you don't have a patch graft? If you don't have a patch graft, no problem. This is what I do if a patch graft is not available. Like, you know, I go to Egypt to operate. Like, you know, I do a lot of charity surgery, and we don't use patch grafts over there. So that's what I do. I get a micro crescent knife. I make a partial thickness scleral, you know, groove. You know, about, like, you know, 7 or 8 millimeters behind the limbus, and another one about like 3 millimeters behind the limbus. And then with this micro crescent, I kind of, like, you know, make this intrascleral tunnel, and I exit above the lip. with a 23 gauge needle. I do something very similar to what I did initially. And I push the tube in from the back. And it really goes in and it's fully covered. And I don't need to use a patch graft. If I have a patch graft, I would still use it, but you know, this is a good alternative. So another special situation. What if you have a scleral buckle? Now, if you have a scleral buckle, you should try to avoid a winged implant. You know, a winged implant will really give you, you know, a lot of headache that you can avoid with the 250 Clearpath. So I'm going to show here, like, you know, I will do a fornix-based incision, fornix-based peritomy. And I dissect well, especially above the buckle. You can see the buckle. And I inject my block. Here I cauterized. And this is a tenotomy scissor. And then I place my 250 Clearpath and see how easily it goes in. Single quadrant, I don't need to do anything with the muscles. And then, like, you know, the anteriorly placed eyelets for the suturing are gonna be invaluable here. So I take my bite in the, like, you know, silicone band itself. And that patient actually did great. So this is the second one in the silicone band. And the Clearpath beautifully sits on top of that. Changing the direction, we're going in, needle going in. This is a patch graft, this is a fornix base, so I'm going to suture the patch graft. Closing. And this is how a double-armed, actually in this technique, how a double-armed 7.0 comes in handy, because I can use the two arms to actually convert it to a mattress suture. So I take one arm, I place it here, and I just pull and take the other arm and place it here, and now I have a horizontal mattress suture, you know, with the traction suture that I originally used, and comes in handy. What do I do for patients postoperatively? So I use a long course, an 8-week course of steroids. 4 times a day for 2 weeks, followed by 3 times a day for 2 weeks, twice a day for 2 weeks, then once a day for 2 weeks. Prednisone 1%. I use an antibiotic, a topical antibiotic for a week. I don't routinely use atropine. I continue all the glaucoma medications initially after surgery, and I stop all the glaucoma medications, or at least the aqueous suppressants, at week 5. Why? The vicryl ligature, the 7.0 vicryl, dissolves sometime, in 95% of cases, dissolves sometime between week 5 and week 6. So I give the patient a date, and tell them this date is going to mark your week 5, and on that date please stop all your glaucoma medications. Why? For 2 reasons. One of them is very theoretical, which is, okay, like, you know, when the tube opens, it's going to bring the pressure down, and if the patient is already taking pressure lowering medications, it's going to go down even further, and you might end up, you have a higher chance of having hypotony. This is more theoretical than real. But the reason is, aqueous suppressants in particular will actually decrease the amount of aqueous that goes through the tube. And if that happens, there is going to be some scarring down of the capsule around the plate, and it's going to scar down on that size, and it's not going to allow further fluid to actually be extruded through the eye later on. So you don't want to have aqueous suppressants when the tube opens up. That's key. What do you do with the ripcord? Do you have to use a ripcord? No. When is it useful? Ripcord is really useful in patients in home, they have a higher risk of hypotony, or not necessarily have a higher risk, but hypotony can have disastrous outcomes in them. For example, are myopic patients more at risk for hypotony than any other patient? No. Myopia is not a risk of hypotony. Myopia is a risk of complications of hypotony. So if you have a hypotenuse eye that is myopic, they are more likely to get suprachoroidal hemorrhage than other patients. But they are not necessarily more likely to become hypotenuse to begin with. So myopia is a case in which hypotony can actually have a bad outcome, high myopia. But higher risk for hypotony, like uveitis, or patients with prior vitrectomy, so they don't have the tamponading effect of the vitreous in the back, so they more easily have choroidal detachments. And number three, surgeons who actually do children who have conditions with thickened choroid or anything like that, like Sturge-Weber syndrome, these are more likely to go hypotenuse, and these are cases in which I definitely would use a ripcord pin. So, what size? If we talk about Perline, for example, the Clearpath comes with a pre-placed 4.0. 4.0, what it does is that it gives you limited but real limitation, or it's like a safeguard, but it would not limit the fluid outflow so much. You will still have a functioning tube. If you want a little bit more safeguarding, then you should go for the 3.0. 3.0 gives more safeguarding. If you want complete occlusion, and this is typically not done primarily, it's done to close a hyperfiltering tube, then you use a 2.0 Perline, which we're going to see in a second in one of the cases. So when do we take it out? Ripcords are traditionally used for two purposes. Number one, until the tube opens, the pressure may be elevated. If it's elevated to very to high degrees that you're not comfortable with, some surgeons decide okay, it's 3 or 4 weeks, I'm gonna pull it out. I never do that. I never pull the ripcord prematurely, because it's almost always gonna be a disastrous scenario. Almost always. I have not done it myself on one of my patients. I've had mentors who did it in front of me every single time. It just kind of puzzles me sometimes, why do you do something exactly the same, and expect a different outcome, yeah. So I always take it out after the tube opens. So I use it for the whole purpose of preventing secondary hypotony. What is secondary hypotony? It's hypotony that happens after the vicral ligature dissolves. Yeah, and this is how I actually remove it. I remove it in the clinic, very simply, very easily, at the slit lamp, like this. So if the conjunctiva is real thin, the patient doesn't have a thick tenon, I just go in with my jeweler's tooth forceps and kind of like, tease it out. And I pull it like that. Okay? But sometimes it's not as easy. So this patient, for example, has a thicker, it's almost like a granuloma here. It's a thicker, tenon on top or whatever. It's not I can't do it just with the forceps like I did. So this is what I would do. Also at the slit lamp. Of course, you need to bathe them in topical anesthesia, literally. I go in with the scissor. Seriously, I emptied half a bottle on that patient prior to doing this of topical anesthetic. So this is a very thick flap. It's probably never gonna was not gonna happen without using a scissor. So the early complications include hypotony. So if the hypotony is really mild, I would do a reformation of the anterior chamber using a cohesive viscoelastic, like a Provisc or Heline. If it's a little bit more, I would ligate the tube with 7/0 vicryl. I can do this really with MST instruments, microsurgical instruments, and I can do it inside the ACE, and I like to do that. Or also using micro surgical instruments, I can put in a tube plug, a 2O proline, to give complete occlusion. If I have tube obstruction by fibrin, which happens sometimes after the tube opens, if you have an intense fibrinous reaction, and it just condenses and organizes, and it blocks the tube, then you inject alteplase or TPA, tissue plasminogen activator. If you have a vitreous strand, which I try to avoid by doing very proper vitrectomy for any vitreous prolapsing through the pupil or anything like this, I leave no vitreous in the AC at all. But if you do, then you can YAG it. If you have a deep tunnel and the tube is actually embedded in the iris tissue, and the iris tissue is occluding the aperture of the tube, what you can do is use the argon laser to shrink the iris away from the opening of the tube. You can also flush the tube with BSS to get rid of any fibrinous reaction or whatever that's blocking the tube if you don't have TPA. After about 2 to 4 weeks after the tube opens, the fibrous capsule kind of starts to grow thicker, and this can result in what we call the hypertensive phase, in which the pressure goes up after an initial period of pressure drop. And if you have a hypertensive phase, all you need to do is start them on aqueous suppressants and keep your fingers crossed. Now, this is a patient who had choroidal detachment. I used atropine, not responsive to atropine, still had hypotony and choroidals, not responsive, several days. Patient is frustrated, in the waiting area, bad mouthing you, bad surgeon, all that. Then I put in this tube plug in, and pressure went back up, but like, you know, it reversed the thing and the patient was happy. That's more important. So if you have tube obstruction with fibrin, you, at the slit lamp, you actually give TPA. This is how I do it. Go in with the needle and just inject it. The pharmacy can advise on the formulation. I like to do a lot of things on the slit lamp, obviously. And one more thing that I wanted to show you is the AC reformation. So the AC reformation, there is one trick that is really helpful if you're going to do this at the slit lamp. So this is a flat chamber, obviously, and the tube is actually oblique here. If you have a flat chamber with iridocorneal touch, where do you want to put your needle to refill the chamber if you don't want to take the patient back to the operating room? You put it above the tube, because this is the place that is, like, you know, in which the iris is actually guarded by the tube itself. So it's the deepest part of the anterior, the peripheral anterior chamber is where the tube is. So this is really where you need to open if you're going to refill the chamber in the clinic. So I put in a speculum. I go in with the side port, and a lot of people like freak out from using this in the clinic, but I don't. And I go over the tube, oblique. And this is Helon. And you give it a good fill. That patient did amazing. Like, you know, I kept her like in the clinic for like an hour, and like, you know, she went from like, you know, counting fingers near face. Like after an hour, she was like 20, 40, and she was like, you know, what did you do? See immediate, you know, almost immediate result. You put them on atropine twice a day afterwards and call it a day. And any questions?
Please. Okay, so first of all, it's great to have you here. That was an amazing presentation. Really interesting and really useful tricks and tips on glaucoma surgery. I have 1,000 questions, but I'm just going to make one. Based on the 250 hypotonic result versus the 350, and there are studies comparing 250, 350 results and 350, 500. But have you considered about not using a ripcord as a standard basis for your 250? And the question is, how often in your cases do you actually take, do you have to take the ripcord out on the 250 Clear Path that you're using?
Excellent question. I'll answer from the last one because I'm gonna forget. So I like to take it if the pressure is above the single digits. I don't like to delay taking out the ripcord. Why? Because you don't want to limit the size of the capsule. So pressure is in the single digits on week 1, like on week 6, which is the first time after the tube opens. I will not take the ripcord out, and I'll see them a week later. If the pressure goes up in the teens, then, like, you know, I take, even if it's low teens, any double numbers, I will take out the ripcord. If, like, you know, the pressure is still in the single digits, which happens quite often with the 250, that's why I'm saying, like, you know, I really, like, I'm having a lot of patients on no medications, single digit pressure, or a pressure of 10 to 12.
And the ripcord in place.
With the ripcord in place. And I, you know, in that case, like if I have a pressure of 8 and it's maintained at 8, then I will not take it out. Now, how often do I not use the ripcord? All of us are biased by our like experience, and we do something one way, and then we have a bad outcome like that we attribute to something that we think is responsible for the bad outcome, and then we try to kind of modify this thing until something happens with what we're doing, and then we try to shift to another technique. So I was not doing ripcord at all, and I had a series of with the Clearpath, because the Clearpath, it doesn't have a ridge like the barbell. The barbell has a ridge, and it does stimulate, theoretically, it does, in my opinion, it does stimulate more fibrous reaction than does the Clearpath. So I was getting a lot of hypotony at week 6. In one particular week, I do anywhere from 6 to 10 a week, tubes. And 1 week I had patients in the waiting area, hypotony next to a hypotony, next to a hypotony, next to a hypotony, and I was getting very depressed. So I'm okay, I'm gonna start using keeping the ripcord, and that was a year ago or so. And it still happens because a 4.0 does not give you full occlusion. So I still see hypotony, but certainly not as much. And again, I don't fear hypotony because I intervene right away. In the clinic, if the patient is really upset, if the patient is not upset, it really depends on the patient. Not high risk, not very upset, kind of I spent enough time with them preoperatively, and I told them about this very potential complication, and they understand, they're not freaking out. I will just keep them on atropine and see them every other day or something. The patient is very upset, they can't see, whatever, is really dependent on that, on this one eye, then I would refill them right away. And yeah, it works. It works. So, please.
In your experience, how compares 250 Ahmed Clear Path to traditional Ahmed valve long term?
So we don't have long-term data in my experience, but on short-term data, big difference. And this is why they have very different indications. For the Ahmed valve, FP7, it's only for bringing down the pressure immediately. If the pressure is really high, or if I want to safeguard hypotony in patients with uveitis or other, very old, frail patients, what we call in the US, old white lady. Old white lady is Ahmed valve. So they have very different indications in my mind. The Ahmed valve is not really in competition with the non-valve tubes, in my opinion. The non-valve tubes are in competition amongst themselves. That's really how I think. But the indications of the Ahmed valve, the NVG, I would not have an NVG of pressure of 50. I would not have the patient wait for 5 or 6 weeks with high pressure. All the other pressure lowering methods, fenestrations, or if you use a nylon wick or any of that, they are not reliable. They can work one time and not the other. But I don't want to take that risk. I just want the pressure lower the very next day. So I use an FP7.
The tube is exactly the same like in a barbell?
Absolutely.
The dimension?
Same dimensions.
Okay.
In the FP7, and the barbell, and in the Clearpath, they're the same
But you said
dimensions.
some people were having trouble.
The ligation is a little bit harder.
Why is it harder if the tube is the same?
You ask these guys. They say it's exactly the same material. But truth is, and I'm being very honest, no, it's harder to tie, for sure.
So there's other thing.
It's harder to tie, but we have the solution for it. So,
Yeah, that's right.
yeah. So this works like magic. It's extra loops. It just works great. So thank you so much. I really enjoyed having you guys. We can do a demonstration on the cadaver eyes for whoever wants to see the tube and
Okay, so water is not passing. You guys see this? You guys see that air bubble going up and down?
Does everyone see the air bubble going up and down, passing the water?
Anybody? So this is what it is. We want to make sure that the tube is watertight. So this is watertight tube. So you have air in an air column or an air bubble, and as you're trying to inject the DSS, it's not really going through. And you know that your tie is great and that it's watertight. We can do another tie just to demonstrate it for you guys. We have water. The thing is, like, when I bring it in focus here, it's totally out of focus on the screen. So, yeah, so it's in focus now. And the down and the non-dominant hand. And then free throw.
Γιατί τα ανοίγεις εγώ τα ποτά.
So here you lay it flat, and then you pull, and then using the two fingers, you tighten it. You see it, guys? This is key. And you see the saucerization, or how like it became like so much thinner here in the middle. So this is really key. And then a couple more. And we tighten it with the fingers. So this is really watertight. So we tested it before. So suturing is done with a ATO from the Scleral. And we have the So this is how I roll it in the finger, like this. This is the taco, or the burrito. And then I get the 1.2. And we'll typically go under the conjunctiva. So I'm going to try to do a little dissection here and see if it actually works, and I'm going to try to put it in through there. So you kind of hold it like this, open that little incision. And push. Yeah. After we are done, I want every one of you to kind of hold this in your hand. Right? Hold it. Obviously, it's much easier if you do in real tissue, but you get the idea. So it goes through like a small incision. And then you kind of suture it here. So we're going to get the 809 line.
Πώς θα τα πούμε κάπου σε κάποια ώρα.
Βέβαια, το να παίρνει. Αυτός είναι. Αλλά δεν είναι. Βάζουμε στα μάτια και δεν θα βγει. Το έχει κάνει. Όταν το λέει, θα το όλο μαζί. Ότι είναι η ίδια. Για να είναι εντάξει, όμως τουλάχιστον για εβδομάδες δουλειάς. Δεν είναι για να κάνω ράβια, έτσι. I think we get it. I mean, we've seen the